Prescribing Action Group. This is a group that is part of the California Improvement Network, which is an organization within CHCF that focuses on improving care delivery across the state. During this webinar, we're going to walk you through both how the action group will be structured over the next several months, and we'll also give you just a little bit of orientation of what CHCF is working on and why we care so much about the topic of safe prescribing. And we're also going to welcome one of our faculty members, Diana Coffa, to talk about San Francisco General and the work they've done to create a safe prescribing culture. So, Christine, okay, I've got the ball. Let me move ahead. So the agenda for today, we're going to do some welcome and some quick introductions so that you know who's on the call and who else will be participating in the action group with you. One of the best parts of an action group is not just expert faculty and learning content, but sharing with each other. Some of the best ways I've learned when I was a medical director of a clinic or a medical director of a health plan was from my peers, how they solved some of the same problems I faced, because no one understands your life trying to make it work in a residency clinic like someone else is doing the exact same thing in another region. We're going to talk about the purpose of the action group and the specific things we want to accomplish today, as well as what we want to accomplish over the course of the action group. We'll introduce the faculty who will be your partners over the next several months, and then talk about CHCF perspective and why we're so committed to this. Then we thought we would start with an example from San Francisco General. What does good look like, knowing that not any clinic has this down altogether, but San Francisco General has been working on a safe prescribing culture for many years, so Diana Coffa is going to take us through that. And then at the end, we'll talk about the design of the action groups, with the calendar, the web portal that we'll use to host documents and organize the work around the action group, and the homework we're setting up for you between now and the next webinar. I wanted to show a map of California to be able to show how well represented you are of the entire state. In Southern California, we have Ventura, White Memorial from Los Angeles, and Loma Linda from San Bernardino. From coastal California, we have Salinas from the Natividad group. From the Bay Area, we have Contra Costa and Alameda, which is Highland Hospital. Northern California, we have Santa Rosa. And Central, we have both Fresno and Modesto. So it's a great opportunity for you to learn what's going on across the state and learn from each other. We are very happy with the representation. These are the objectives that what success looks like after this action group is complete. We want to support clinics learning about how to reinforce safe prescribing practices. This really has to do with what is the infrastructure you create, so no matter which resident, which attending, which staff person is in the system, there's consistency about how patients are treated and how pain is managed. We want to support learning about how residency clinics introduce evidence-based addiction treatment, and I'll go into a little bit more why we're focusing on that, as well as chronic pain management, and this is specifically the use of buprenorphine in primary care. We want to focus on teaching resources for residency curricula so that when you walk out of this action group, you have ideas not only about how to create a clinic culture of safe prescribing, but how to teach residents about safe prescribing. And ultimately, to develop and implement an action plan for your clinic. That's a smart, very focused goal. It's measurable, that you're able to say clearly at the end of 9 months, we made a difference. And starting small is fine, but again, it has to do with setting yourself a target for what you want to work on, and we'll talk more about that as we develop. And finally, as I mentioned before, we want to be able to support learning from each other. So I wanted to highlight our faculty. As I said, I'm Kelly Piper, and I work with California Healthcare Foundation, and I've worked in safe prescribing in my role as a medical director of a clinic, and we implemented a big safe prescribing initiative as well as a San Francisco health plan. Diana Coffa is the residency director at UCSF San Francisco General, and she'll be talking today, and you'll get to know her as well. Christine Cristobal has been working in chronic pain at Kaiser and also is managing the whole portfolio of work that we're doing here at California Healthcare Foundation. Sherlyn Abramovitz is an addiction specialist at Highland Hospital, and she's on the call today, but we'll be focusing on having her teach in future webinars, so you'll get to know her. And then Dan Alford is a nationally known specialist in addiction medicine who's leading a program called Scope of Pain, and he and the team you see on the slides today will be, you'll get to know them in depth on October 1st when we have our in-person convening. So I first wanted to talk a little bit about CHCF and why we care so much about this topic. And what I always like to start with a slide because it represents that there's many things that went into creating this epidemic, but a big piece of this was us in the medical system. There's a doctor saying, look, you've got to stop thinking that one little pill is going to solve all your problems. You need to take 4 twice a day. When we didn't have a lot of understanding about the impact of what these pills did and a lot of other resources, we ended up relying heavily on opioids to try and solve a lot of problems, some of them related to actual physical pain and some of it related to the suffering of poverty. And because I'm a family doc, I always start with a patient story. Beth is in her late 30s, chronic low back pain, unstable employment. The PCP inherited her on 180 milligrams daily of morphine plus lorazepam, and always requests for more because her pain was consistently 8 out of 10. No matter, you look back through her chart when she was on 2 Vicodin a day or 180 milligrams of morphine, the pain was 8 out of 10 consistently. There were some concerning behaviors. There was a urine positive for cocaine that she had a reason and excuse about. Once the drug test was refused, she couldn't pee, she was in a hurry. And even though she had a lot of physical limitations and depression, she never followed through with physical therapy or behavioral health referral. And one day the PCP got a call from the coroner, and she was found dead of an accidental overdose with the PCP's bottles in her hand and some other medications that the PCP didn't know about. And I think that if all of us knew the truth, this happens to everyone, and this was my patient. All of us, based on statistics, have had probably some patient die of overdose without whether we knew it or not. And I did a lot of things wrong. The Medical Board of California put out new guidelines in November of last year, which are very helpful and very clear on what are the highest risk prescribing behaviors, and I did many of them. Combining benzos and opioids is one of the highest risk, along with the use of methadone, in which case she was on it, and I didn't realize that. I did not accurately diagnose substance use disorder and recognize how much in danger she was, and either taper her off opioids or switch to buprenorphine, which would have been a much safer choice, both for pain and her opioid use disorder. Didn't insist on a behavioral health evaluation. The way I think about it now, if I had told her if you broke your femur, I wouldn't just give you crutches without a cast, but we often give a piece of pain management treatment without the behavioral health component, which is equally important. Didn't assess whether they improved her function. In fact, if you looked at the timeline, her function got worse and worse. Her pain never improved. In fact, her pain got a lot worse on opioids. I think many of you have had those patients who come in and say, I hurt all over. Does your neck hurt? Yes. Your back hurt? Yes. Your fingernails hurt? Yes, they hurt the worst. And this is often caused by opioids, where you get this hyperalgesia where everything hurts, and then so much opioid dependence that there's lots of mini withdrawals all day long, which the patients think are worse than pain when they're actual withdrawal from the medicine. And finally, most importantly, she shouldn't have been on opioids at all for chronic low back pain because it actually doesn't work. And one of my favorite moments, I was in a large conference where the presenter said, hey, someone raise your hand if you've ever cured someone of chronic low back pain through daily use of opioids. And of course the answer is no one, because they just don't work. So how did we get here? When I was trained in the 90s, this is what I was taught, and this is what I was teaching residents. Pain is the vital sign. Your job is to keep pushing pain meds until the pain score reaches 3 out of 10. And we are also reassured by a New England Journal study which said that only 1% of people on chronic narcotics get addicted. And of course, we found out later that that study was on inpatients. It was profoundly flawed. A lot of pharma advertisement and misleading statements led us to think that these were a lot safer than they were. What we know now, that addiction and chronic opioid use is much, much more common. 30% is problematic use, even more. The higher you go, the higher the death rate. We used to think there was no ceiling, and now we understand that it's all incremental increases, but over 100 is particularly called out as being high risk. But what I think we didn't focus on either is that there's so many medical complications, and often this can help patients get on board with the desire to wean. There's lots of sleep apnea, osteoporosis, hyperalgesia, depression, more and more disability. And what was most profound for me to understand is the way that long-term opioid use really changes the brain neurochemistry. A great example that I heard was someone saying, if someone's pancreas is broken, we give them insulin all day long, and we don't punish them if they go out and binge on Krispy Kremes. We don't see, you've got a sugar for 400, we're firing you from the practice. But on the other hand, if we put someone on chronic opioids and their brain has gotten so used to it that their dopamine axis is suppressed and their brain is broken, they can't make dopamine, they run out, they go out and get some Vicodin from a friend to get through the day, and we fire them from the practice. And that's something that there's more and more attention to, that for the people who are already dependent, if opioids aren't safe, it's our job to help work with them to try and come up with an alternative to make sure that they stay safe. So CHCF is taking this on as a major initiative, and we're focusing our strategy based on the Obama administration's strategy. Both the CDC and the Health and Human Services are focusing on 3 areas to try and decrease the death rate and improve safety. One is what we're doing in this group, safe prescribing, teaching providers and trying to develop infrastructure that support evidence-based safe prescribing and making sure that everyone has the resources they need. Secondly, even if we practice perfect safe prescribing, there's a population of people who are already dependent and addicted, and it's our job to try and take care of them and help them get the treatment they need. So medication-assisted treatment has tremendous amounts of evidence behind it that lowers relapse rate and lowers death rate, and we're going to be focusing on that as well. And finally, to spread the use of naloxone to stop the death rate, and this has been proven to lower death rates in communities where it's been widely spread. So just a little bit about how we're doing that, promoting safe prescribing practices, the specific high-yield interventions that we'll be focusing on in detail on October 1st. You know, for acute pain, there's a widely spread movement in EDs to use opioids judiciously in small doses and to pay attention to the 90-day cliff, which means that if someone's been taking opioids for 90 days, 50% of those people are still on it 2 years. So that's a key moment to get people off so they don't stay dependent. In the chronic pain, there's very high-risk behaviors that we'll be focusing on, combining benzos and opioids, using methadone, which is responsible for about 1/3 of the deaths, monitoring for and acting on concerning behaviors. Often clinics will start using urine drug screens, not know how to interpret them or just ignore them, and we'll be talking about how to create safe systems of care for these. Using buprenorphine for opioid use disorder and times when there's mixed pain and substance use, because often in academia they'll say buprenorphine is just for substance use and we have to treat pain differently, and most of our patient population is in that gray zone where there's a lot of mixed pain and opioid use disorder or overuse, and it's sometimes hard to tell the difference. And finally, to recognize the high-risk threshold. With high-dose threshold of morphine, 100 milligrams or 40 milligrams of methadone, avoiding escalations above that threshold to prevent people from getting to the high doses like that's my patient, and then where possible, slowly weaning down to safer doses. So the second strategy is focused on medication-assisted treatment, and this is really about don't create opioid refugees. These are the people who are dependent on opioids, the doctor cuts them off, there's no access to buprenorphine, and they end up either getting pills from the street or going to heroin, and we've certainly seen a big uptick in heroin. So in our efforts to do safe prescribing, we shouldn't abandon this population. And finally, I already told you the story, but again, understanding that addiction is a chronic neurochemical disease, it's not a moral disease, and that a lot of the behaviors that drive us crazy, that make us so frustrated, we can better understand in the context of what's happening in the brain and what happens to a brain that's cut off from dopamine. It's really important to know that and treat that as opposed to seeing it as a moral behavior of our patients. And the last piece is the increased use of naloxone, and we'll be talking more about that. This has been incredibly effective when used in drug treatment settings, and there's a movement to try and spread across the state to prescribe it for people who are on chronic opioids. Interestingly, it's been shown to drop the death rate even if it's never deployed, and it may just have to do with having that conversation with a patient about you are on this high-risk drug. This is a drug that can help you from dying, can often change risky behaviors even if the naloxone is never used. I wanted to give you a sense of our target. We have good public health data and good data from the CURE system, and we'll be talking more about the new updates to the CURE system that are very exciting. So each of you can see where you started. In the 5-year period of 2008 to 2012, this is the death rate for your county of the total number of deaths per 100,000, and then in parentheses is the actual number of deaths in that 5-year period. Of course, with the epidemic continuing to go strong. Those numbers might be higher for 2014 and 15, but we don't have those stats yet. And you can see compared to the California average where your county stands. And then we also took the Cures data to show the total number of milligrams of morphine equivalents in your county prescribed in 2013 and then translated that into Vicodin per person per year in that county. And it's a little shocking to think that in California, across the board, there's 123 Vicodin per resident per year prescribed, which means if you don't take any Vicodin, someone else is taking twice as much. This is a pretty shocking statistic, and as often helps with the call to action. And we can provide more detailed data on your particular county if that will help you get a call to action going in your community. And then because I'm a family doc, I always like to end on a story. Molly was a patient of mine when I left Petaluma Health Center to go to San Francisco Health Plan. I left a lot of my patients on high-dose morphine and signed them out to new doctors. And 5 years later, I ran into her sister, and she says, "Are you Dr. Pfeiffer?" And I said, "Yeah." And she said, "You know, Molly loved you. She thought you were the best doctor ever. And she was so upset when you left because she got assigned to a doctor who insisted on weaning her down off those pills. And I have to say, your leaving was the best thing that ever happened to her. She has lost 50 pounds. She's got more energy. Her pain's better. So, sorry to tell you this, but it was really good that you left." And I always tell the story mainly to say we can have a patient-centered approach to this problem. It's not about identifying addicts, cutting them off, and adding to stigma. It's really about being a partner with our patients and helping them figure out what they need and what's best for them. So now I'm going to turn over the ball to Diana, and if you have any questions for me or for Diana, we'll have a period of time at the end of Diana's presentation that you can ask.
I think that's a really great introduction to the problem, and I'm sure that all of us have struggled with these exact same problems with the special added spice of doing it with residents, which makes everything just a little bit more complicated. So what I'm going to talk about is some of the things that we have done. We have, as Kelly alluded to, been working on this issue really very actively with a pretty large multidisciplinary team and a lot of institutional support for years now. And so I think we've had some real successes that are worth sharing. And then I know, too, that we will be able to learn from you and some of the successes you've had. So I don't want to get up here and pretend like I have all the answers, but maybe I have a few. So Kelly talked about the problem. I'm going to go a little bit in a different direction, too, thinking about the problem. So even before opioids came into the picture, doctors didn't like chronic pain patients. There's this quote here on the screen from a book called The Body in Pain by an anthropologist who studied pain. To hear about pain is to have doubt, and to experience pain is to have certainty. So anthropologists, medical anthropologists, actually studied the physician relationship with chronic pain starting back in the 70s, and were alarmed to find how much we disliked our chronic pain patients, even then, even before opioids. And what they identified as the fundamental issue for us, well, there were two. One is that we didn't understand it. So to hear about pain is to have doubt, meaning when somebody describes their experience of pain, you have no idea what they're actually saying. You have no idea what people mean when they say pain. You don't know how much, you don't know how bad, you don't know if they really mean depression, you don't know if they really mean addiction. It's very difficult to define. I've actually had patients who I worked with over the course of years. I had one gentleman finally say, after a couple of years working with him, I realized when I say pain, I don't mean pain, I mean suffering. That's what I'm talking about. And it was a breakthrough moment where we could get a little more nuanced and realistic about what he meant when he was using the word pain. So we're confused by it. And the other thing that bothers us about it is that we can't fix it. And as physicians, we are quite frustrated by things we can't fix. And so even going into the opioid epidemic, we didn't enjoy working with these patients. And I think family doctors are uniquely positioned in a way as specialists in not knowing what's going on. We're a little bit better at handling these patients than many other specialties. But it's still a struggle. And then in the early 2000s, mid-2000s, we began to see a real upswing in opioid misuse, in prescription opioid misuse, overdose, dependence. This is an image on the bottom right of an album cover by the rapper Eminem. He actually got sober from drugs in the mid-90s, didn't make any albums, and then in the early 2000s released an album called Relapse, and the B-side was Refill. And the album cover is actually a picture of his face with made out of prescription pills. And I use it as a reminder of how completely common and normal and mainstream the use of prescription pills had become even when this album was released in 2000. And now it is almost as common. First-time use of opioids is almost as common among high school students as first-time use of marijuana. It's highly epidemic. So that complicates the matter even further, where not only now are we confused by the pain, but we're confused by this other disease that we like even less as a culture, which is addiction. So what have we done at San Francisco General Hospital to help us start to get at these issues more effectively? And I'll say, before I go through this slide, I think the first and most important thing we've done, and you'll probably hear me talk about this over and over again, is we have worked really hard to diminish and diffuse the stigma associated with chronic pain and diminish and diffuse the stigma associated with addiction. The two do come together. The two are really frustrating for providers. But more importantly, the two diseases are both absolutely life-changing for patients. And if we can move into a patient-centered perspective about both conditions, I think we do a much better job of taking care of our patients. So specifically, things that we have done that I'm going to talk about today are we've worked hard to develop consistent policies so that everyone in clinic is playing by the same rules. Somebody on the whiteboard mentioned that different providers are doing different things. Kelly pointed out that means residents are being told different things by different preceptors, which is really confusing for them. And of course, it's confusing for patients to not know which rules they're playing by today. So we'll talk about our policy and how we developed it. We also developed a Controlled Substances Review Committee, which is a multidisciplinary group that actually reviews cases, answers people's questions about chronic pain, and ensures that we are all following the policy. As a residency program, we've developed a robust curriculum that focuses not only on pain management and safe opioid prescribing, but also on addiction treatment and specifically medication-assisted addiction treatment. And lastly, we're going to talk about reminding people that non-opioid treatments for chronic pain are effective and, in fact, in many cases, more effective than opioids, and trying to shift the conversation away from opioids when we talk about chronic pain and over to other options for treating chronic pain. That's our goal for today. So let's start by talking about our policy. What I'm going to do is go through some of the basic areas that we want to make sure are addressed in a clinic policy where residents are practicing. First, I want to talk a little bit about how we developed our policy. It is quite difficult, as some of you know, to get buy-in from providers who have been practicing a certain way for a long time. So we spent over a year putting together a policy. We probably had nearly 24 meetings where anybody was invited. We would have meetings with 20 people breaking up into small groups. There would be the UTOX group and the refill policy group, so that everybody had an opportunity to weigh in and hash it out. By the time we had finally written the policy, we were then able to distribute it throughout the clinic and require that every single provider sign saying they understood it and would follow it. It was not a smooth or fast road to that point, but it was critical that we took the time to get to full buy-in. So the components that we focused on in the policy and that I would recommend others focus on, first, we made some recommendations about an initial pain assessment. What should be in there? So we want to make sure people assess addiction and overdose risk, and we want to use standardized tools to do that. Using your gut to decide who's at risk and who's not leaves you vulnerable to things like racism, classism, personal bias. We know that providers do a very bad job of assessing if they don't use objective tools, so we really strongly encourage people to use those. We encourage a mental health assessment, since so often untreated mental health issues contribute to the experience of pain. And then we have worked very hard, as I think many of you have, to shift the focus away from a pain score and towards a functional assessment. What we're really aiming for is for people to be able to function in their lives. So we ask people to assess physical function, emotional function, social function, and then sleep specifically. One of the other nice things about including this in your initial assessment is that it can become, for example, the sleep can become an independent target for interventions. So again, it's a way to shift yourself away from the opioids and towards these other functional targets. Once you've set up a policy for initial assessments, then you want to give some guidelines about reassessment at standard intervals. So we require that moderate risk to high risk patients are seen monthly, and then low risk patients who have been on opioids and stable for a time can be seen every 3 months. We require that they're monitored for functional improvement at these visits, and that if function is declining, opioid discontinuation be seriously considered. We also have a specific refill policy. Different residency programs are different, but certainly in our program, residents are not always available every 28 days on the dot for their patients. And so refills can become fairly chaotic for patients. So we had to make some really clear guidelines about what was allowed and what wasn't. We do allow one early refill a year. People do sometimes lose things. We will give them one a year. But any early refill needs to be reported to our clinic's Controlled Substance Review Committee so that we can keep track and see if anybody is actually getting more than one refill a year, and we need to review their case. We also have a really clear policy about monitoring for misuse. So essentially, we're monitoring for signs that the opioids are causing harm rather than helping the patient. And we do that by requiring a urine drug screen on every single patient, so basic universal precautions, and requiring a cures report on every single patient at least annually. Patients who are high risk, we require more frequent urine drug testing, and moderate risk, sort of an in-between frequency, about every 3 months for moderate risk patients. And again, we use these standardized risk assessments to prevent us from profiling, which unfortunately is something that we are all vulnerable to doing. The other part of the policy, so beyond the written policy, I think you're hearing me use this language, and I want to highlight it. We work really hard to steer our culture away from a sort of punitive, judgmental, legalistic culture. So I won't let people use the word pain contract. We call it a patient-provider agreement. The pain contract language, especially when someone comes to me and says, my patient violated their pain contract, so I'm going to cut them off. That is sort of a policing, legalistic approach to care, and really what we're trying to teach people is a medical approach to care. So the narrative might be, my patient is showing signs of addiction, so I think the opiates are hurting them, so I need to stop prescribing those opiates, right? The analogy I use is if you had a patient on lisinopril who had a blood pressure of 90/40, you wouldn't say, well, my patient's being a terrible hypertensive, so I'm going to punish him by taking away the lisinopril. You would say, this medication isn't safe, therefore I will stop prescribing it. And we try to shift people into that mindset, partly because it supports much more collaborative and helpful communication with the patient. The other thing we do is we role play these conversations, and I'm sure many of you do this as well, but we role play conversations at the beginning of prescribing about discussing risk, discussing benefits, and discussing when we would have to stop the medication. And then we role play discussions at the end of prescribing about discontinuation and why I need to discontinue and what I'm going to do for you instead. And as Kelly, I think, very well said, we don't fire people because they have developed another disease. We identify the new disease of addiction and we take responsibility for treating it.
Diana?
Yes.
Would this be an okay time to pause and answer the first 3 questions? So there are 3 questions that came through the chat. The first one is, how do you overcome lack of mental health access, particularly for Medi-Cal patients?
Yeah, I'll tell you, we have created a chronic pain group in our clinic because even though I think we are lucky to have fairly good access within our own clinic. We have some behavioral health providers in our clinic. Even they don't necessarily have the expertise to handle patients with chronic pain and the specific issues around helping them manage that. So we have a chronic pain group, which I'll discuss a little bit later, that's co-facilitated by a physician and a psychologist. Although I've seen models where it was just like it was a nurse practitioner and a medical assistant. There are a lot of ways to put together a group, but that's one way.
If I could jump in, the nice thing about practicing now as opposed to before 2014 is this isn't just our problem anymore, it's the health plan's problem, and that in LA, for example, almost all Medi-Cal patients are either in LA Care or Health Med, and then if their members aren't getting mental health access, then that's something that could be advocated. You could communicate with LA Care, there's not an overnight issue to kind of go from no access to full access, but the good thing is that the state's holding the Medi-Cal plans accountable for getting that access together, and there's someone to work with on that.
And there's a second question. Who is on your review committee?
Yeah, great. I actually have a couple of slides coming up about the review committee, but I'll tell you right now, we have, let's see, a physician's assistant actually chairs the committee at this point, a nurse practitioner who runs our back pain clinic, me, a physician. We have 2 psychologists, 1 family therapist, and 1 who runs the chronic pain group. We have a medical assistant, a nurse, a clerk, and someone who, a data manager, one of our QI leaders in clinic is on the team to help us manage our data. It's a big group, and we do that intentionally because we recognize that people see different angles of patients. So the nurse will often say something like, oh, this guy drops in every 3 days, and he's always yelling. So she's seeing things the providers aren't seeing. And then we invite the primary care doctors or providers, whether it's a nurse practitioner, physician's assistant, or doctor, we invite them to come too and discuss the case with us as a group.
And I would say that a lot of clinics are doing this with a much leaner model with just a medical director and a behaviorist, just medical director, behaviorist, pharmacist. And I think we're showing you a very mature model, but we don't want you to get discouraged that that's the only way to do it. There's ways to do it with far less resources.
Yeah, thank you, Kelly, for pointing that out. The truth is, I think what's most important is having someone who's on the ground and making sure you have a mental health provider there. Because even if you don't have, or someone who has some expertise in behavioral health, because even if you don't have referral access, we have found it really useful for the psychologist to just give advice to the provider about how to interact with the patient more effectively.
Diana, so there's one more question in the chat and about 15 minutes left. So the question is, do you send all chronic pain, I think it's, all chronic pain to pain management? And if so, what if they fail to follow through with those referrals?
We do not send people to chronic pain management for the most part. One of the commitments we've made as a teaching clinic is we actually really want our residents to know this stuff. And so we deliberately keep the patients with our residents so that they can primarily manage these issues. And that's why we've developed this review committee to support primary care providers in doing it rather than sending people to specialists.
Great. And I actually almost missed this fourth question. How many opiate patients are managed through the residency clinic? It seems like monitoring early refills may take up a lot of time.
So our clinic, we have 45 residents. We're a 15-15-15 program. And about half our patients are seen by residents. The other half are seen by faculty or nurse practitioners. Our total chronic pain opioid panel is probably around 500 to 600 patients. So it's a lot of patients. But we have worked really hard on our appointment system for chronic pain patients such that people generally get their appointments on time, and we actually, early refills are not so common anymore, so we don't spend much time monitoring those. Should I keep going?
Yes, please.
Okay. So somebody asked about our Controlled Substance Review Committee. I'll tell you a little bit more about that then. We call ourselves the Pain Squad because that makes people want to refer to us. It's a little more friendly. Providers love having the Pain Squad at their back. The overall sentiment from providers about the Pain Squad has been that they feel supported and they feel like it's easier for them to have difficult conversations knowing that this oversight committee has agreed with their plan and supports it. So we review patient cases and develop recommendations for providers. We also develop clinic policies and modify them as needed. We also manage pain-related QI projects in the clinic. Sorry, there we go. We get referrals from 3 different places. One, if a patient is sent to our clinic from another clinic on opioids, we review the case. 2, and most of our referrals come from providers, nurses, medical assistants, clerks, behaviorists, anyone who is concerned about a patient can refer directly to the Pain Squad and we'll review the case. And then 3, we actually have a registry, as I mentioned, of opioid-using patients. We search the registry and we look at patients with ultra-high doses or positive urine drug schemes or who are on unsafe drug combinations. And we'll provide recommendations directly to providers from there. Now, I will say, I mentioned that we invite providers to the meetings. That's another way to kind of diffuse whatever anxiety people might have about the recommendations. We also tell providers our recommendations before putting them in the electronic medical records so there can be a conversation and we can make sure that providers are comfortable with what we're recommending so they don't feel boxed into a corner before we actually put the recommendations into the electronic medical record. On the Basecamp site that you will be using, I have uploaded or provided some of the materials that we use in our review committee. So you have access to our referral form and also to our recommendation form that we use to guide our recommendations. And our recommendations fall into 3 categories. We make recommendations about chronic pain management. So we'll make recommendations about medications, physical therapy, alternative therapies. We make recommendations about mental health, which is so often connected. And then 3rd, we make recommendations about substance use treatment. So we will suggest referrals, we'll suggest that somebody get naloxone, or we'll suggest Suboxone in the clinic, or buprenorphine naloxone. So that brings me to the next slide, which is we do have a big focus on medication-assisted treatment for opioid use disorders. I mentioned that we really frame this as it's now your responsibility to treat a new illness if you're discontinuing opioids for someone who you think has addiction. As Kelly mentioned too, there are a lot of people who live in the gray zone of having both addiction and chronic pain, and buprenorphine really is a promising drug for that gray zone. It can be used to treat chronic pain. Typically, when you're using it to treat chronic pain, you divide it TID rather than giving it once daily. And so we do teach a little bit about using that. We train, as of this coming year, we're going to be training all of our residents with a buprenorphine waiver training, so they will all have X licenses to prescribe. And we have a partnership with our own county's buprenorphine induction clinic where they send patients to us for maintenance and we can send patients to them for induction. I'm happy to talk more about buprenorphine in the residency setting if that's of interest to people. I mentioned too our chronic pain group, which I think of as really central to our chronic pain management program at the Family Health Center at SFGH. Our chronic pain group, and there are many models, is a combination of a cognitive behavioral therapy model and an acceptance commitment therapy model, in addition to some just basic relational work. One of the things that characterizes chronic pain is a deep, deep isolation and loneliness. Often people feel like nobody understands them, nobody wants to be around them, and giving them a group of people who understand them can, from what I've seen, be one of the most healing things we can do for people. I said here in the second bullet, better functional outcomes than opioids. Opioids have, let's be honest, they have pretty terrible functional outcomes. There are no studies showing improved function with opioids. There are studies showing improved function among chronic pain patients with cognitive behavioral therapy and with physical therapy. So in my mind, those are actually the first-line treatments, and opioids go after those treatments. I think this is my only slide on the chronic pain group, but again, I'm really happy to share more as time allows later in this course about how we developed that group. We have a manual that I'm happy to share with people if they want to set up their own chronic pain group. We rotate our residents through the group, so every resident spends 4 sessions with the group, and I think it's a really powerful time for them to begin to understand how small a role opioids actually have in chronic pain management and how much more can actually be done for patients who suffer with chronic pain. It's a really lovely experience for them. So patients say things like, I realize I'm not alone. I still have pain, but now I can live with it. It doesn't bother me the way it did. I have one patient who used to say, mind over matter. If you don't mind, it doesn't matter. That was her take home from the chronic pain group. And after just the first session, everything changed. I have hope now. It's so beautiful to see the transformations that people undergo. And residents find themselves more interested in chronic pain, more empathetic about chronic pain. They start to learn about group visits, which I think is a critical learning area for residents. And they sometimes actually enjoy working with chronic pain patients, which feels like a coup. I've mentioned a couple of times how important I think non-opioid pain treatment is, and I'm just going to throw a few numbers at you. We know that in studies, opioids for chronic pain reduce pain on average by about 10 to 30%. They're not a magic bullet. If you look at studies on cognitive behavioral therapy for pain, you'll see pain reductions of about 30%. If you look at studies of gabapentin or other anti-neuropathic pain agents, you'll see reductions of 40 to 60%. So opioids are by no means the best treatment that we have. They're one of many treatments that we have. So whatever we can do to increase our non-opioid pain management options, the better. So ways to do this: bring in students or interns from other professional schools. We have an acupuncture school in the neighborhood where we can develop partnerships. Bring in attendings who have additional skills, somebody who does group visits or hypnotherapy or acupuncture. Do group visits, bring in volunteers, volunteer massage therapists, that kind of thing can be really powerful. And link with low-cost community resources. I always present this slide to my residents just to remind them how vast the options are for chronic pain treatment. You have pharmacologic options. You have physical or mechanical options, including physical therapy, joint injections, surgeries, heat, ice. You have complementary and alternative medicines with more or less evidence behind them, right? Mindfulness-based stress reduction, which is a meditation technique, actually has a fair bit of evidence for chronic pain, whereas something like Tai Chi has less evidence. But people with certain conditions do find it helpful, and I'm happy, again, if people have questions, to actually talk about the evidence for those things. And then psychological therapy over in the corner. And what I recommend for residents is that for every single chronic pain patient, they make sure that they have at least considered, if not tried, something from each of those 4 quadrants. And this helps draw people out of the conversation being entirely about opioids and really thinking more broadly about chronic pain management. And you, I hope, can use a slide like this to think about where you can access non-opioid alternatives for your own patients.
A lot of what you guys done is extremely impressive, and a lot of it must have taken some rearrangement of funding streams in order to pay for things like clinical pharmacists to manage refills and to pay for the time of people who are on the committee. So I wonder how you convinced your administration to go along with those changes.
Yeah, I think it's a really good question. I will say we don't actually have a pharmacist do refills. The PCPs or the attending who's on, if the patient drops in, do the refills. So there aren't extra funding streams from that perspective. But we have received administrative support, like for our pain squad meetings. Honestly, the only person who's getting protected time for that meeting is the chair. So the physician's assistant gets 5% time to run the pain squad. And I think the pitch to the administration is about how much time is wasted and how much burnout is generated by poorly organized systems around chronic pain, right? The patient who drops in and yells at the nurse, and then the nurse goes to the attending, and then the patient yells at the attending, and then everybody's mad at everybody. I'm sure you have events like that. And that was compelling enough for our administration to try to put a little money into trying to get a handle on the problem.
Hi, Diana. Quick question. So we are working on building a registry and an auto refill program for patients, for example, who are low risk, who can be seen every 3 months but need a prescription written every month. That we have, for example, a locked box with prescriptions pre-written, and they're on our registry so we can follow those. Have you guys done anything like that or found that to be useful?
Yeah, we did have for a while a nurse clinic where providers could leave a prescription for her, and we actually had a protocol for her where she would assess patients for, sedation and signs of toxicity from opioids, and do a little bit of a functional and pain assessment too. It was useful. It was a nice way to take those low-risk patients and sort of reduce the number of visits they have to have. She ended up going to another clinic, and we decided in the end that it was just as easy to for these really low-risk patients, to just give them 3 months' worth of prescription at a time. So we didn't end up continuing it. But it is, I think depending on the patient population you're targeting, it can be useful.
One I answered was that can residents get DEA X licenses for buprenorphine, and the answer is if you have a DEA license, you can get an X license by doing an 8-hour training, which can be done online or in person, and we'll talk later in the curriculum about how to access that type of training. The second was, how do residents bill for osteopathic manipulation? I'm wondering if Santa Rosa can answer that, just because you've got a lot of residents who are DOs. I know in Petaluma I think we would just bill for the primary care visit that the osteopathy would be part of, but does anyone on the phone have experience actually billing for manipulation?
Yeah, they just bill as a regular office visit.
We used to have an osteopathy clinic, and I think that's what we did too.
Okay, great. Are there any other questions for Diana or Kelly?
Yeah, a quick question regarding buprenorphine. I know a lot of institutions, like, for example, Swedish Cherry Hill has been doing this for a while, where all their family medicine residents are trained on buprenorphine before graduating. But how did you set that infrastructure up? Like, did you have X amount of faculty that were trained as well to oversee, and then how did the institution take that somewhat of its own stigma around buprenorphine?
Yeah, I think that's really important to check out what your institutional stigma is. I think we're lucky that we had more institutional support than institutional resistance, but that'll be different at different places. Infrastructure. So we started small, and I think, as Kelly's saying, that's the way to go, right? So we started with a couple of residents got trained, the ones who were really interested, and 2 faculty were trained. And whenever a buprenorphine patient showed up, the resident would page one of their buprenorphine faculty, and we would talk over the case on the phone. So it was really small. It was kind of ad hoc. More and more what would happen is a buprenorphine patient would come in, and another attending would see it, and they would see the resident paging me instead of talking with them, and that would make the attending want to know more about buprenorphine and ask me about it, and I would set them up for the next training. So it kind of snowballed organically that way, to where now I'd say we probably have a third of our faculty with X numbers. Residents still page faculty if there's not a faculty on site who can precept or prescribe the buprenorphine for them.
And we will make sure to have substantial amount of time on buprenorphine and how to build that infrastructure during this action group. So even if you don't get your questions answered today, we'll be spending a lot of time on it.
This is Ken Saff. I have a question. Diana and anyone else, we live in a very siloed institution where nursing and medical services are very separate. Do you have any suggestions for having the collaboration that's needed to have the work being shared by various people and not just be on the workload of the resident and or physician, like the entering data and so on?
So hi, Ken, you're the buprenorphine expert. You should be asking all the questions about buprenorphine. So your question is about support for QI work. Am I right?
No, it's on the front lines work.
So okay.
If we're doing all this data entry about, significant histories and screening tools, how can we do it so that it's not all on the plate of the provider, the resident, the physician?
Yeah. I mean, I think you're talking about team-based care.
Right.
So
Any suggestions for that?
I think that's the opioid risk tool, which I alluded to, is a 5-question tool that could be done on paper or electronically and entered by a medical assistant. I think looking for those opportunities is really smart. Yeah, so the naloxone, which we haven't talked about much, but our nursing team is really involved in making sure that people know how to use naloxone appropriately, for example.
Yeah. We're looking at the COMM tool, and it's got a registered trademark. It was developed with NIDA funds as well as, big pharma. Does anybody know if it's public domain?
I'm not familiar with it, but I can look it up.
Hi. I'm sorry to butt in. This is Ilana from Boston University in Scope of Pain. Ken, I think that you can get it and use it through through Inflexion, through Pain EDU. It is copyrighted, but I think if you get it directly from them, it's perfectly fine to use.
So can we make it part of our electronic record? That's really the question.
That I don't know.
Okay.
And so talking briefly about screening, we were debating which tool to use as well, and using a lot of the resources from ANEDU, it sounded like the SOAP had some of the most, it was the most sensitive and specific with the most validity behind it, with some good data behind its use, but obviously it's kind of a pain in the butt to use. It's a big questionnaire. So how did you guys decide to use the SOAP the ORT instead of the SOAP, and have you found it to be sensitive and specific enough for your needs?
For me, it's about simplicity. It was really about finding the tool that people would use, because a tool is better than no tool. And I find it's not a perfect tool. There are some odd things about it, but it's not so insensitive or non-specific. It's in the sort of 80% range. So it's not perfect, but I don't think this area is an area where perfection is attainable.
All right, well, this is Christine again, and what I'm going to do is mute everybody just so that we can make sure we have a clear recording through the next couple of slides. But thank you so much, Diana. That was a really great overview of sort of what good looks like and what all of the organizations can be working towards over the next several months. I am going to take a few minutes to talk about the various elements of the action group and what we're going to be doing together over the next 9 months. There are a number of ways that we are wanting to support you in your learning and your work over the next several months. And you can see them here on this slide. We've got some convenings. We have 2 in-person convenings. The first one is going to be on October 1st, and I think you should have all received an invitation for that, and we're going to send out the information, a flyer, and a registration for this event. This event is going to be an all-day event divided into 2 sections. The first part is a morning section from 9 till about I think noon, and it's going to include scope training from our national experts, Dan Alford from Boston University and some of his colleagues. And then in the afternoon, we are asking all the Residency Action Group participants to stay on, and we'll say goodbye to the rest of the public who joined us just for the morning. We're going to ask all of you to stay on, and we're going to be kind of diving deep into more of your planning around developing the infrastructure that you'll be building over the next 9 months or so in your residency clinics. And we'll have the scope team there, and we'll have other faculty like Diana and Dr. Sharona Abramovitz. So that is the convening on October 1st. We'll have a second convening at the end of the action group that's going to be in March, and we're still, that date is still open. And that's going to be a time for us to really come together and share what we've learned, harvest all of our learnings, and kind of hear about what your plans are for the future. We have webinars planned. So we have 7 webinars. We're extending them, as Kelly mentioned, from 60 minutes to 90 minutes, just so we can make sure you have tons of time for questions and discussions. I'll show you the calendar in a second of when these webinars are scheduled. But we have invited you to the first 3 webinars, July, August, and September webinars now, and we want to check out the rest of the schedule with you just to make sure there are no major conflicts with dates. In addition to the webinars, where we'll be bringing faculty like Diana and Sharon and Dan Alford and Kelly to talk about various key topics, we're going to have office hours. These are 1-hour WebEx sessions as well, and these are going to be less structured and a little bit more open, and it's going to be an opportunity for each of all of you to bring any issues or challenges or questions that you have to the forefront and get some consultation. So the way we're going to structure this lightly structured office hour is we're going to ask that 2 teams, and we can make assignments later, 2 teams come with any specific challenges or questions, and then we know that the rest of the teams who are on the office hours will also learn from hearing kind of about those specific challenges. In addition to the office hours, we are providing some implementation coaching for you. And I'm your implementation coach for the duration of the action group. And we're offering these monthly coaching calls, and I'll be scheduling those with you in a little bit. But it's an opportunity for us to really get into the nitty-gritty of the goals that you're trying to achieve and any barriers or challenges that are coming up. In addition, we've got some as-needed coaching that's available from our clinical faculty, including Diana Kaffa and Dr. Sharon Abramovitz. And then finally, the other element of the action group is so that this isn't just, you know, a nice time for you to log on to these webinars, but you're actually getting some work done. We're structuring this so that you are working on a particular QI project. And we'd love for you to develop aims in 2 different topical areas. One is an aim where you can be thinking about how you're going to improve your clinic culture or infrastructure. And then the other one is in developing your residency training program. We have a couple things we would love for you to do before you get to developing your SMART goals. One is we've developed a very brief baseline assessment. The link to the assessment is there. It's a Google form, and it's about 15 questions, and it basically asks you to rate your organization, your clinic, in terms of the infrastructure that you may or may not have set up for a safe prescribing culture, your training, and some culture and attitude questions. In addition, I'd love to get folks signed up for the coaching calls with me on a monthly basis, so I'll be sending out a link from Sign Up Genius, and this will help us schedule some standing monthly calls with each other. So, Kelly, did you have a comment?
I just wanted to say quickly, Christine, in her other work as a professional coach of clinics, both on the commercial side and the safety net side, I just want to say that in case you're not sure what this means, coaching call, her job is really to just have a chance with you one-on-one to help you think about barriers and how to get past them. They really are wrapped around your needs and will be very helpful as we move along.
Great, thanks. Some other pieces of homework here. So I mentioned that we want to see you developing your initial SMART goals for the next 9 months. There are 2 goals, again, one around kind of infrastructure and setup, and another one around setting up your residency training. we think that it would be great if you as a team kind of set up all of your meetings on a shared meeting calendar you might have in your organization, so just keep track of all the different meetings and assigning responsibilities amongst your teammates for the various pieces of the work as you go along. And we're going to ask you to share your SMART goals with the rest of us on the next webinar. Here's a little bit of guidance on development of SMART goals, and this is the kind of thing that I can dive in more deeply and give you feedback on our coaching calls. So Kelly put this really nice table together to help us all see what a specific, measurable, achievable, relevant, and time-bound SMART goal might look like for your work. So you will get the slides after this call and have an opportunity to refer back to this slide as you, as a team, create your own SMART goals. A little bit more guidance on this next slide. This is a helpful tool in prioritizing SMART goals, because I'm sure there are dozens of things that you could think about working on over the next 9 months. But we ask you to think about the level of effort something is going to take versus, in addition to the impact that it might have. And we think honing in on the top 2 quadrants there, the things that might have high impact but not take a lot of effort, or the things that might have high impact and take high effort, those are the things to consider as you are picking your SMART goals to focus on. And here's just a sample agenda for you as a team. This may be the first time you're meeting together as a team working on safe prescribing culture in your residency program. So just a couple of things to think about for your agenda in terms of brainstorming and coming up with your SMART goals, and then making assignments so that you can make sure that there's follow-up on your work. Okay, so finally, just a review of the next steps, and then we'll open it up to questions. In just a few minutes, I'm going to open up the very short webinar poll that'll pop up on your screen. Please, again, visit our base camp using the invitation you should have gotten this morning. Send me any conflicts or questions you have about our calendar and our topics. Don't forget to start scheduling your team meetings together so you can begin the work that we're kicking off today. I reviewed the homework for you, and once again, before our next webinar on July 22nd, what we would love to see are your responses to the assessment and also your draft SMART goals. And then the final slide is a list of all the contacts for you if you have any questions for any of the faculty.